Today our workshop panel is on women in surgery, and we have 4 wonderful surgeons here to talk about their experiences. And we'll start off with introductions with Misty Humphries.
Yes.
Okay, great.
So my name is Misty Humphries. I am a vascular surgeon. I've been on the faculty for 3 years at UC Davis. I trained at UC Davis for my residency in general surgery, and then I did 2 years in the University of Utah, and now have come back to do vascular surgery, and I have a focus in research at UC Davis as well.
Family.
I have no children, but I have a wonderful husband, and that will be the theme throughout every single woman up here, is that we have wonderful husbands. Yes, that's my family. So.
Hi, you guys. Glad to have you here. I'm Diana Farmer. I'm the chair of the Department of Surgery here at UC Davis and a pediatric surgeon specializing in children by training. Like a few folks, I've been all around the country in various jobs and training in my lifetime. I have been married for 31 years to a guy that I met when I was a medical student, and we have I have 2 stepchildren and 3 grandchildren, and more to come.
Not children.
Yeah, right. Stories.
Just checking. So I'm Julie Freischlag. I met some of you yesterday at our mentorship session. So I'm the Dean of the School of Medicine and the Vice Chancellor of Human Health Sciences here at UC Davis. I've been here about 7 months. Prior to that, I was Chair of Surgery at Johns Hopkins for 11 years, and prior to that, I was a Division Chief of Vascular Surgery, because I'm a vascular surgeon too, at UCLA for 5 years. I trained at UCLA for both general and vascular surgery, and I'm married to 22 years because I sort of had a false start. I was married to someone else for a bit, a medical oncologist, not sure what I was thinking then, but so I have 2 stepchildren as well that are 34 and 35, and then I have a son who's 19 at the University of Maryland, and I have 1 grandchild. She's 6 weeks old and lives in Berkeley, brand new to do that, Diana and I have been friends for a long period of time. We met in a leadership course, and Misty I met actually when she was a fellow at Utah, and we're newfound friends, but have known people that have known both of us, but we just met each other since I've been here.
I'm Kathrin Troppmann. I was an undergrad at UCLA in the 80s, and then went to medical school in Philadelphia and came back here in '92 to UC Davis, and I never left. So 22 years ago, I came to do my surgical residency and became a faculty member in 1998. I do a lot of gastrointestinal surgery and minimally invasive surgery with a focus on colorectal surgery. And I used to be in charge of our 3rd-year medical student clerkship, so as the medical students would come by our service in their 3rd year, we would introduce them to surgery, and I kind of organized them, was sort of their mom while they were on the service. And I'm married to a transplant surgeon now 9 years, and we have a sweetie little 6-year-old girl, Sophia, and Max is 8. And so I have 2 jobs, namely my surgical job and my active mommy job right now. And both are incredibly thrilling. So.
We'd like to open it up to questions. You have a wide range of ages and various levels that we're all in now. So we can answer questions from what it's like to start a job, to get in a job, to move up the ranks and all of that.
Watch the comment about the wide range of ages. Not so wide.
I mean, like, look how young they are.
There you go.
I meant that. From there, she's almost in this group.
Yes.
Just checking on you.
So who wants to go first?
I'm the oldest.
Absolutely.
So I work in an ER right now, and one of the physicians that I work with, she always said that as a woman in medicine, she felt that there was she had to put a lot more pressure on herself to excel in order to be accepted at the same level as her colleagues. And perhaps that's not applicable to you guys, since you seem like you would go to excel anyways. But I was just wondering if you've ever seen that sort of atmosphere where there was kind of a higher standard.
So I'll tell you that I trained at the 80s. So I finished med school in 80 as she was in high school. And when I was training, and I was the only woman around, so when I went interviewing for surgery residency, I would be the only woman in the room. And I was the sixth woman to finish at UCLA, and I was the first woman on faculty in surgery at both UCSD and UCLA, the second one in Milwaukee. So as I did that, I actually think it's true. We talked a bit about this yesterday in mentorship, that I do think that there was demand, a lot of demands on you had to be not good, you had to be really good. And it wouldn't take much for people to see a blemish and to not give you that opportunity. I know for a fact, I told this yesterday, that when I applied to the surgery program at UCSF, there were 6 women, and they were all put on the bottom of the pile by the chair then, because he said he wasn't going to take any women into that program. And so that happened in 1979. So yes, I think they do. Now, the thing that has happened that's been so exciting is now half our applicants to surgery are women, and we're seeing more and more come into the training programs. So as the volume gets more with both women and underrepresented minorities, it's better. Still, though, I do think that there's pressure pushed in the sense that it is a sort of a high contact sport. It's very demanding physically. There's lots of intense moments with it that I do think there's still some issues. Yesterday I mentioned I got an email from one of our second-year medical students just a couple weeks ago saying someone had told her that she really can't be a surgeon, that women can't. Now her chair of surgery is a woman, the dean's a woman surgeon. I'm like, I'm not sure where they got their information, but, and it had to be in the preclinical. You know, she's a second-year medical student. So there's still some noise about that. And I think the other thing we need to have to do is not all of you are going to be chairs and chiefs and that and deans. You know, you're going to go be a surgeon just like guys. Not all of them are. And this is the first time we've seen women that perhaps want to practice and perhaps be at the top all the time. So I think we need to realize that there's going to be good women and good guys and great women and great guys and different aspirations. But I do think it's true. You sort of came right behind me a moment.
Absolutely. When in the early days of interviewing we all, if you were married, people took off their wedding rings. You just didn't talk about it. But that's all changed. And I think, women make great surgeons. I think they may even make better surgeons, although I guess that's not good to say. But
Well, they have different traits that they bring to the table.
Absolutely. And I think there's a lot of natural manual dexterity in a lot of women. I think there are lots of things that make it a great field for women. And I think you're right, more importantly, it's a great field for men and women, and I don't think that really influences the decision making at the entry level in surgery anymore, and it really shouldn't. It's what you like and what you love. That's the most important thing to find.
Yeah, I remember when I was an undergrad and I asked a micro teacher for her opinion about that question, and she said, you just have to be better. But so there certainly has been that thought, but coming to UC Davis, we've had a culture of it's almost genderless in a respect. You know, our prior surgeon and now Dr. Farmer and Dr. Goodnight before her were very interested in just having hardworking, honest, strong candidates. And it didn't really matter if the candidate was a woman or a man. This year's incoming class, all women. Last year graduating class was all men. Well, there's 2 military guys. And when I was an intern, 5 of the 6 of us were women. So even in '92, our institution already had a culture of inclusion and diversity, which I think actually makes for a better group when you have diversity in the group. And I think women just bring a different set of qualities to the table but I think all of us have an interest in excellence. And I think as long as you carry that, people can see that when they're interviewing you.
I can say, as the final common denominator on interviewing, it is for our surgery applicants, it is completely gender blind. It was not a plan to have all women residents. We rank them in the order of preference, and that's just how it fell out. But there was no thinking about, we ought to have 3 women and 3 men or something like that. It was just completely based on what we thought was a good fit and quality. So you're entering at a great time in medicine. Over there.
Can you please have a comment on the career lifespan of a woman in surgery? After all the training and after you've got all of your credentials, how long can you actually operate before your body just gives out?
How old are you?
Yeah. So I'm going to be 60 in January. I think I'm still working pretty good. And I do know women who have worked through their 60s. You know, we don't have many women in their 60s and 70s that are surgeons, but there's some. She's probably 66, 67. Yeah, true. Right.
And the chairman of the department in San Francisco is a transplant surgeon, still practicing in her mid-60s.
Right. So I think it's not. It's a good question though, because I think one thing you do, men and women have to protect yourself from injury. And she actually is in a field where there's a lot of ergonomic injuries these days because of this minimally invasive. It's minimally invasive for the patient, but maximally distracting for the surgeon, where you lean over. And even when we did distal bypasses, you know, I with your neck and things. So making sure you're ergonomically correct, because many surgeons end up with some neck issues and back issues, and depending on how much you operate. And I did have a dream, you know, where none of us are the tallest people you'll meet, but when you're at an operating room table, you need to be at the same height. So many of us spent a lot of time on lifts, and I actually think that's good, because you would raise yourself to the right height for the partner that was training you. I did dream when I became the one determining the height of the table that I'd make everybody kneel. You know, that was one of my dreams.
Cut a hole in the ground.
But now because of that, I actually think women are better, because we're used to being on lifts, so we arrange it so you're not leaning over. But you have to be careful. You have to stay fit. You have to really make sure I find myself at 60, I get a little more fatigued if I'm up all night. That's not something I do, and as a dean, I don't take call, and I don't miss that now. I had years of call, and it's great not to take a lot of call. But I think it's more fatigue and pacing yourself in other ways so that you're alert and awake versus physical. But I know many men that have had back and neck injuries. I must admit, mainly because we're not older yet, I don't know as many women that have had injuries at all. And maybe we're a little bit smarter about it to do it. And also, it may be the lift thing. You know, I was thinking that we are used to always being at the right height, so we're not leaning over or doing funny things. But your field is different with all the things you have
Well,
to
I
do.
have a chief resident on the service now, David, who is quite tall. So I almost need 2 lifts just to meet him. But I can imagine he's probably had some problems. But I think your question is important in that it is important for us to take care of ourselves. As Dr. Freischlag was saying, I still go to the gym regularly, and I have to work out, so I have the stamina to sometimes do these long cases. Some of my colorectal cases can take 6 hours or so, and you know, I'm squatting and for part of it, or having to do all sorts of interesting maneuvers. But so it's important to take care of yourself and get rest and eat well. Those things are all very important to kind of keep up with the residents and the med students too. You have to have that stamina. The nurses will take breaks during the OR or the OR techs, and you're the constant force, so you have to have endurance.
Can I just follow up briefly? Since you just had 2 babies, 8 and 5 and 9 years ago, did you find that affect your health and your ability to stand through those long surgeries right after you had the babies?
Well, right after I had the babies, you're tired, especially if you want to nurse your baby, which I wanted to do. So it is tiring until the baby sleeps through the night, which is usually at a few months. But it kind of, surgery prepares you for that kind of life, for being a mom, you know, those long nights. But it's just all kind of the same. It's that endurance and having a goal and having something that you absolutely love, whether it be your personal or your professional life, and you just do it.
The last trimester is tough operating. When I had my son, I was 40, and I did an open aneurysm 3 days before I had him. And, and I couldn't really reach the table. That was the main issue, and I had some swelling in my hands, and it was actually my father-in-law's friend I was operating on, and luckily it was May, and so the fellow was really good, you know, at the end of the year. So we finished, and at the end of that case, I walked in and said, you know, I really need to go home now, you know, because I'm tired. And I did take 11 weeks off because I was an older mom to do it. But you are right, because you're a surgeon, you can wake up, do something, go right back to sleep. So having a kid wake up in the middle of the night as a surgeon, you don't have to go clamp an aorta. You just have to feed the baby. And the baby is nice and sleepy and cute, smells good, you know, it's not colorectal. So then you put him to bed and you go back. So to me, it was easier than waking up to be a surgeon in the middle of the night. There's no question. But pacing the rest of it, now she's got interaction issues here. They want to talk to her and see her, and she needs to be around because now they like you. And then in about 5 years, they won't. And then you don't have to spend that much time with them. And then now my 19-year-old, I text once a day. So this is the time where she really needs to spend all her time with her children, I think, because by the time they're 13 or 14, especially, I've never raised a girl, but that they get really weird. And so but I think you can do it, and part of it is just making sure you pace yourself a little bit. Now, I did go into low right heart failure, and my albumin was low. No one knew to tell me to stop, and so I was a little sick for a few weeks afterwards, but that was part of us learning how to pace yourself to make it better.
So the answer is yes, I would say. Dr. Freischlag and I certainly remember the times, and were part of conversations where there were no maternity policies in universities, because, particularly in departments of surgery or in some practices, because there had never been a woman, so there was never a reason to think about that. What's happened that's really nice is they're not just maternity policies, but they're family leave policies. So really what's applying to women is also applying to men, and I think it's really been a nice balance, life balance for everybody. And the answer is certainly in all of your training environments, so in medical school and in residencies, everywhere, there are really excellent policies around family leave, and most practices are quite accommodating as well. That usually ends up being a decision that gets made with your partners. But we're not as unusual anymore. And again, as half of the trainees, as half the medical students become women, we are hoping that we'll have half the surgeons at least be women, and then it really reflects the start. But the accommodations are really excellent in most places.
I had a few of my faculty, they work part-time. Just if you work part-time, you make part-time money. And call is a big deal in surgery. So you do need to have to figure out how you come back and take some call, because that's where everybody, and when I came back having my baby, I took off 11 weeks. And my one partner, Gary Seabrook, who's a very nice guy who had a baby a year ahead of me, but his wife ended up staying home with the baby. He put me on call 28 days in September out of the 30 to make up the days that I owed them. And I had to go remind him that I still had a baby, that I had a baby, and that I will make up the call over the next 4 to 5 months, the weekends and the days, but I can't do it all in September. And in his mind, he goes, I just thought you want to get it out of the way. I said, yeah, but I can't take 28 days of call in September, to do it. So sometimes you have to tell them, but I think people do, and a lot of guys need time off, or they have to be, in your partnership with another surgeon, I assume he does some of this too, to do it,
Right,
yeah.
and a few years ago, Dr. Howell, one of our deans, our associate deans, had worked to develop a flexible policy for our hospital. And UC Davis, I think the campus here has a similar policy for flexibility, especially during maternity leave and paternity leave and family leave. So even if you're taking care of an elderly parent, or the parent or a family member has a medical problem. And I think that that's very forward thinking, and I think other programs in the country are thinking along those lines as well. But there's definitely flexibility in the workplace. Just yesterday I spoke with 2 of our hospitalists who are siblings, and the Joels, I don't know if you know the Joels, but basically they did a timeshare for a while because they had some significant family issues. And I think that it's just become part of the day-to-day world of a physician. And many of the men also have similar interests in spending time with their children and being around for the childbirth. So, and being there for perhaps the first week after the baby's been born or longer. But I think the flexibility has made a big difference in the quality of life for the physicians and surgeons.
Certainly it's never easy, and people have different strategies for how they manage things. I have to say one of our faculty members, one of your partners, had triplets not that long ago. So that's a project. Yeah.
But you were accommodating.
Yeah.
You made arrangements. We brought in help. That would be me. And then we've accommodated for her. She can't do as much, or she does different things. We've tailored her practice to help her. It's all a team sport. We don't work together all the time, but we're all on the same team. We're on the team of making everybody successful. So.
And I have terrific partners. There are about 6 guys in my division, and they were all very flexible with me. When I was pregnant, I took a lot of my call when I was still relatively early in my 3rd trimester, and then at the end of the 6 months, so we do 6 months at a time, I did the last part of the 6 months. So I was able to have some breathing room in the time right around the birth of my baby, but still did my share of the call, because I do think it's important, if you want to be respected as a women's surgeon, is to do your part of the deal too, you know, not ask for favors. Although certainly they'll grant you those opportunities when you have to leave. You know, I had to leave because I needed to deliver relatively quickly. Both of my babies were a couple weeks early, but that's just part of the deal. And the guys are very, very open-minded because they're all fathers. Every single one in my division. One has 4 kids, and the other it ranges from 2 to 4, but they all have children, and they all are fathers, and it's all important to them, their family lives.
What was your original draw to surgery, and what do you most enjoy about it?
Start here.
I didn't want to be a surgeon. I wanted to be a pediatrician. And then I discovered I didn't like kids, so that was sort of a problem. So I did surgery as my first rotation in medical school. When you're in your 3rd year, you do a certain number of clerkships, so you get exposed to everything. And I thought, well, I'm never going to be a surgeon. I'll just do that first, and I'll get it out of the way. And I fell in love with it. You are the captain of the ship. When people are running around and screaming and freaking out and the sky is falling, you are the person that walks in and says, it's going to be okay. I got this. We're going to make it better. And I love that feeling. And I also really worked well with the people. There is a surgical mentality, I believe. It's different in men and women, but you are just a certain person. I'm very driven. I'm very type A. I'm very, my husband would say I'm very crazy. I like to think that I'm very organized, and I'm very meticulous is a better word for it. But, and that's how I am in my practice. To be a surgeon is to meet somebody for the first time and say, hi, you don't know me, but let me cut you open and fix you. Let me help you. Let me take care of you. That's a huge responsibility. And I love knowing that my patients come to me and they don't know who I am, they don't know anything about me, but they trust that I'm going to make them better. And I am, as a surgeon, you touch people's lives in ways that no one else does. As somebody that does medicine, you tinker with their medications and you maybe change things, but as a surgeon, they ask you for so much of yourself. And I love that. I love that a lot.
So I have a different story. In the very beginning, the one thing I knew I didn't want to do was pediatrics.
You're a pediatric surgeon.
I know. So that wasn't my plan at all. I absolutely knew I didn't want to do that. I thought I might be some kind of a surgeon, because again, I think I had a sense of that about my personality, and I didn't like writing as much. It seemed to me that in internal medicine on my rotation, you were just writing notes all day long. I thought, oh. So I also did my surgery rotation first, a little bit with the idea to get it out of the way and see what I thought, and it was on trauma in Seattle, and I just loved it. So I was sure I was going to be a trauma surgeon. That was my plan all along. And then I really enjoyed the technical part of pediatric surgery. And so I was driven to pediatric surgery for surgical reasons, not really for the love of children reasons, but the being a child advocate and caring about kids really came later. But it's just fun. It is great to have a skill in your hands. What you can do is a skill that you can take with you anywhere you go. I do a fair amount of global surgery work, and you don't have to be handing out pills. You can make a difference with the skills you bring, and that's a lot of fun. It's a great field.
So similar, I was going to be a pediatrician. I guess you knew that. Yeah, everybody was. And I did surgery first to get out of the way also, so that's the other things. Back then, no one really thought of that. And I did orthopedics first and then general surgery, and found I was good with my hands, and I liked the disease process. And I ended up liking vascular surgery when I was an intern at UCLA, because we follow them a long period of time. So some of our patients we operate on, some we don't. We follow. I got an email from one last week that I had done a 9-centimeter aneurysm on in 2003, and it was amazing. They're still calling me that many years later, but good work. And he was having some issues and was hospitalized. So you hear from them all the time. And then I'm sort of an expert on this one procedure, taking ribs out of people, which are young athletes, and Misty's helping me with that program here at Davis. So we just got an email from a Division I lacrosse player from the East Coast that is coming out to see us, and so we're bringing an Olympic athlete team that was the first one I did here. So these high performance athletes have been fun for me to do, because as a dean I'm in a lot of meetings and a lot of issues, so nothing can bleed or clot, and that's sort of what vascular is a lot, so it has to be down there. But again, I think it's the team. You get to work with lots of teams in surgery, so you have nurses and anesthesia, so you're running a team. You get to really make a difference, like they said, as well too. And then you also really can turn people on to that. I bring students into the OR and see what goes on, and it is exciting. You know, whenever they have those TV shows where they come and film at Hopkins, they did this. You know, they tried to film rheumatology clinic, and they tried to film that, but they're in the ED. They're watching the surgeons run with their organs. They're watching them do this. You know, so surgeons you do have to want to move. You know, and you have to be someone that makes a decision, and you may be wrong, and then you have to back up, because you have to go forward. It can never paralyze you to make a decision. So if you're someone that takes a long time to make a decision, surgery might be a challenge for you.
I love surgeons and I love surgery, and it's not something I necessarily would have thought that I would do either. I thought I was a primary care personality. You know, I like talking to people, listening to their problems, and trying to make their lives well. And then I realized I also did surgery towards the beginning, so I'd get it out of the way. It's a theme. But then I realized that I absolutely loved the definitive nature of surgery. You have a problem, you can tangibly sometimes make people better within a few hours. They go from near death to looking you in the eye the next day, and I feel so much better. It's incredibly gratifying. But my false perception was that surgeons just had someone wheel them in, they did their operation, wheeled them out, never really had a lot of interaction. And my week is very filled with FaceTime with the patients, probably nearly as much as my OR time. You know, you do a lot of education of patients, telling them about their diseases, talking with them about the options that they have, and you can tell them, I can make you better with this. And I take a lot of pride in helping the patients that no one else really wants to take care of. I take care of a lot of Crohn's patients who have lifelong problems with their intestines, or some colorectal cancer patients who are obstructed from a malignancy, and just being there and being their advocate and helping them get through probably one of the most daunting and difficult times of their lives, kind of as their advocate and as their surgeon, it's incredibly gratifying. And as I went on during the practice and during training, I realized that I really like surgical diseases too. I love the type of pathology that we have and the physiology. I thought for a short while I would do orthopedics, but I really like physiology, and general surgery kind of encompass the anatomy, the physiology, the patient interaction part. It kind of put everything together, and it's just incredibly gratifying. It was at a conference like this when I was a high school student at USC, and I remember a surgeon talking about what he did during his day, and I remember driving home right there by the LA Zoo thinking, this is my job. I am so excited that I have found something that I can be excited about doing for the rest of my life. So it's incredibly exciting and just awesome.
You never get bored. Every patient's different. It's really fun. Yeah.
I apologize if I'm repeating a question I slipped in late, but I'm just wondering if you guys have ever faced people doubting your capabilities because you are women, people are patients, and how you guys dealt with those situations.
I find patients are fine. You know, patients mainly I've never had one patient question whether I should be their physician. And I started being a surgeon in '87 at VA hospitals, a lot of senior citizens that were male. You know, you just present yourself, you're confident, you know what you're doing, and I've never had that issue. It more comes with hierarchy, with jobs and being offered leadership positions. I think that as long as you're qualified, you really pay attention to your outcomes, you do a good job. I think society works pretty much well with you as you being the surgeon, because you expect when you walk in that there's a really good chance. I know my young athletes, they don't blink that the surgeon's a woman. I do think hierarchy, there's very few women deans, there's very few women chairs of surgery. We're talking 15 women deans right now. Diana's in the top 10. I think our club is 12 women that have ever been chairs of surgery in the country. I think there's 6 right now. So it's that leadership thing, and whether that's myth or mystery, jealousy, money, whatever it is. We were just talking about it a little earlier today, whether women want to do these jobs, or do they have the confidence, or they just don't want to be bothered with the politics and this. I mean, there's a lot of insanity sometimes in getting to head of companies and all that, and where will that end up in being? So I think that's where I've seen a lot more inability. I have seen some teams where one partner would steal cases from their other partners, and I don't think it's just the women. Amy had that trouble in Cincinnati, and I think there are some people that are bullies and some people that are odd, but by and large, I think that's going away, and most times it's so visible when people aren't fair, but I really haven't seen a patient issue with that.
I doubt myself. I have less confidence than my patients have in me. And the way that I've overcome that is I have many phenomenal mentors that are women in my life. And 2 of my greatest mentors are sitting next to me today. So one woman gave me a chance, and I walked in her office and said, I'm going to be the next best thing to ever come in your department. And I didn't really believe that, but I said it. And I hope to God she believed it, because she hired me. And then the other mentor, who is sitting next to her, came to UC Davis, and I said, I'm going to help you do whatever you want to accomplish. And I didn't know how I was going to do it, but I just was going to be there, and I was going to help. And that's what women do. We help. We're great. We're team players. I'm humble enough to say, I don't know what the heck you're talking about. And I think that men sometimes don't do that. So where I don't have a lot of confidence, I've struggled with that, having confidence in myself. I am beautiful. I am fabulous. I am smart. And if you don't want to get on this train and go up with me, you better get out of my way. And that's not something I've always been able to say. I've only been able to say that for the last few weeks. But I am. And I just have to believe in myself like they believe in me. And I will be just as unstoppable as these women have been before me. So.
There was a great Maya Angelou quote that was almost that exact. I have a little magnet. I'll make sure you put a copy.
Thank you.
No, but it's, I echo that. That's,
And I do think one of the most potent emotions out there is jealousy. And I've just raised boys, but when I've been had somebody say something bad about me or criticize me, even now, which I think I actually am there, I've accomplished most things that nobody else has, they still will say it's bad. I was just telling them a story earlier today about a talk I gave, because they're jealous. And they do make you pause, going, well, maybe it wasn't so good. Well, of course it was good. It was my talk. It was really good, to do it. So part of it is that jealousy. I think it's the most, I've seen people do weird stuff. When your job as a chair and dean is to watch what people do weird stuff. And a lot that's fueled by jealousy or wanting what you have. They are crazy. And there is a little bit more of that competition in men by and large than women, but I have seen women do it. I had a woman blackball me from a society years ago, a very senior woman vascular surgeon from SUS, and she said, I don't think she's going to stay academic anymore. Really? Of all the things you would say about it, I don't think that's one of them. But there is that piece, and I think now that we have generations of women, our more senior women, which is everybody older than me, that's senior, not me, and it goes up every year, they're tough, the 60 to 70 to 80-year-old surgeons, because they had it really rough. And some of them never got over it, because it was bad. My generation started having kids and started doing those things, so the 50 to 60 are pretty pleasant. And then the newer generation, the 30 to 40s, are partnered with other surgeons. They're independent. They really have this strident piece to them, which I enjoy a lot, that you see it. So And I must admit, when I trained, I didn't notice any of this. I was just going to be a surgeon, and that was it. And I was raised with brothers, and it didn't dawn on me that this wasn't what I was supposed to do. But I'm sure people were saying and doing things. So what we need to do is to go forth and do great things, which also is getting support for each other, and to make sure that we all hear from each other. And we're going to do it differently. I mean, Diana and I have a lot in common, but there's some way she leads that's very different than me and that I'm learning from. And I do things different than her. So I think part of it also is appreciating our differences as well as our similarities.
What was the question your son asked you?
Yes, yeah. When he was 6, I was in a car with him. He'll probably ask you this too. And he said, "Mom, can boys be surgeons too?" Because in his world, and I published that. So if you put that in, boys be surgeons, Freischlag, you'll find him. And part of it in his world, he thought only girls were surgeons, to do it. And I almost said, "No, you can't." And actually, the first time I told that story, I was at Stanford, and I said, he doesn't know that you are, because it's unusual for us to be in a room that looks like this. I mean, when at UC Davis, when I went to talk to the Department of or I guess it was when I was doing the search for Hopkins for OBGYN, we went off to chat with them, Janice and I did, and it didn't dawn on me that 90% of the faculty would be women, because we're not quite there. So we walk in this room, and I was like, whoa, everybody's a girl, and it didn't dawn on me that there would be departments around that, because peds and OB have a lot of women in them now. And I just sat there the whole time. I couldn't even talk, because my department was 30% women or so, but not the whole room.
Sometimes I'm in the operating room and everyone except the patient is a woman. It's quite exciting.
My first case, when Misty helped me with it was all women in the OR. So
yeah.
We'll go here and then here, okay? And then there.
Since we are talking about the disadvantages that could come, what would, in contrast to that, would be an advantage you have over men as women?
I listen. Yeah, I think we don't think of it in advantages and disadvantages anymore, really. I think it's a pretty equal playing field, particularly at your level. And I think individuals have different advantages and disadvantages. So I, at least in my view of it now, there isn't something that sort of all women have an advantage or a disadvantage about, and all men have an advantage or disadvantage about. It's really much more about individual strengths and weaknesses.
There are certain traits, though, that tend to be attributed more to women than to men, and we tend to use those traits perhaps a little more. For instance, empathy and listening and flexibility. Yeah. I can sit with my patient and hold his hand or her hand and look them in the eye and really portray and honestly portray that their problem is something that I really truly want them to overcome. And men can do the same, but it's not as inbred in their character because they haven't had that training or that kind of that freedom. I actually think we're fortunate that we have that ability to sit down with them and show them that compassion. Whether it's something good or bad. If I have to tell them that their pathology came back with cancer, they can see that I'm truly distraught for them as well. And I tell them, we're going to get you through this. I'll send you to the oncologist, but I'll continue to see you for a few years in a conjunction with your chemotherapy and radiation therapy doctors. So I think that is perhaps one advantage.
And I see one that I think overall, not all men and not all women, women can juggle things because of the nature. When you have kids, spouses tend to help, but we sort of want to take it over because what they do is average and not always the right thing. But I see chief residents much more organized with women a bit, and they can organize a team bit because they don't care who wins all the time. It's not all men and not all women. So I have seen that organization. And I think you can raise your kids that way because it's funny. My son answered the phone once for the head of cardiac surgery at Hopkins, and I wasn't home. He goes, parents are out. And I've taught him every time he hangs up the phone, he goes, "Love you." And so at the end of the conversation, he was like 10, to Bill Baumgartner, he goes, "Okay, well, Taylor, thanks for the time." He goes, "Okay, love you." And the both of them just sort of froze, get to do it. And he told me later, Bill said it was so funny because so when my kid answers me on text, it's, "Love you, Mom." and he's a hugger. And I've taught him to be that way. And he still sits on my lap. He weighs 245 pounds, but he wants to, and he sits on my lap. And I love that, to do it. So I think as we raise our kids with more yin and yang. I've seen men cry when their cancer can't be removed at their surgeons. And so I think we are yin and yang more, but I do think there is this piece that doing 14 things at once sometimes can be detrimental, because we've been talking to Misty about what she should and shouldn't be doing with her career right now. But I think that is a trait I've seen. But not all women are. I mean, there are some women that when they're not organized, you go, what happened? Where's that gene? what chromosome do you have? That double X is supposed to make that happen. What happened to yours, to do it? But and you will find men that are very organized as well, too. But I agree with Diana. I tell you, we are so much better when there's a whole bunch of us, different shapes, sizes, colors, genders. When we're in a group, we tend to behave ourselves. And I was in a sorority in college, and you want to see misbehavior, the 56 of us, and people stealing boyfriends and all that kind of, it really got me ready for my career. And but when we're all together, we get catty and we do weird stuff, so I think blending all of us together is a really good thing.
I like having male partners too,
Yeah.
because sometimes
they're matter of fact.
they're very, my husband is very matter of fact, very succinct, and it can be
get
harsh.
over it.
You just get over it, but
it's not personal. I learned that from a male person. When you tell someone you're fired or you can't do this, and I say, it's not personal. You just can't do that, because you would always assume if I took away something it's because I don't like you, but it's not personal. I learned that from my male colleagues. It's just money.
Have you guys mentally and emotionally prepared before you guys go into surgery? Like, what do you guys, your mentality going into that? Like, you're just gonna go for it, or you?
So there's a time whenever you have to wash your hands before you do surgery at the scrub sink. And that's the time that I take to just go through the case one last time. But when I see a patient, I've planned out their surgery. It starts the day they meet me in the clinic. And from the time that I meet them to the time I do their surgery, I spend time reviewing cases, looking at things, looking through the files in my own brain that I've done for their cases before. But the last moment that I have is when I scrub my hands before their case. And I sit there and I just walk myself through every case, or every part of their case. And then I walk myself through their case, the alternative if something goes wrong, and what my plan A, B, and C is. And I walk in with that. The whole foundation of what you're doing now in physics or whatever your classes are, it's actually important. The only thing I have yet to figure out is how algebra comes into play later, but physics I use every day.
Go into anesthesia.
Is that it? Oh, thank goodness, because I couldn't figure a field. But but that's just it. Everything builds on top of that. So just keep learning. When you're in a class, take that time to learn it. Sit there and be engrossed in it for that moment. It's so hard now that we're in this social media and distracting world. Every 5 minutes my phone is going off. I try not to carry my phone with me a lot of times. It means that maybe for 10 minutes I don't answer an email or something, or when I'm in the OR, there's nobody can get to me. The only way they can get to me is if they page me. But that's the best time ever. I love the OR. Nobody can email me. I don't have to check on anything. So I love that part. Yeah.
Okay, this question is real off of what we've been discussing. What do you think of this whole hospitalists versus patients being able to have their doctor follow them, and especially when they're dealing with going on to the part where they're dealing with specialists?
So that's an interesting question about hospitalists. I think there are different roles, and everybody brings different things to the table. The surgical field has resisted the shift work approach to care because we, at least in this country, and it's changing in other countries, and people really are exploring this, but the tradition in surgery has been one very much that the same person who actually saw the anatomy inside you is the best one to deal with your complications and deal with if you need another operation, and so that the continuity of care is a really important tradition in surgery. There are, on the other hand, it is not realistic to say that one person can be available 24/7, 365. So that's why we have partners and we cross-cover for each other. Hospital care has gotten so complex that just having someone who's in the hospital all the time to help manage that hospital care, and patients are constantly coming in and going, is part of what made the hospitalist system evolve mostly initially in internal medicine. But in surgery, there are some people who just manage the hospital part sometimes, but your main surgeon does your long-term care in addition to your operation. So I think it is not as common in the surgical world to have hospitalists, although we do have some surgical hospitalists. But I personally believe that care is the best when there are both of those kinds of folks paying attention to you as a patient. You've got the person who's got the long-term perspective on you, has known you a long time, and you've got someone who's really an expert in the day-to-day management of hospital medicine. So.
And some of that is because of efficiency. You know, the hospital used to go to sleep in the evening, and not much would happen to patients at night. Now that's gone. In the ICU, you're constantly being monitored. And frankly, as you get older, your expertise of managing people in the ICU, if you haven't been there, isn't so much. And you really want someone in our hospital, you know, we have residents there at night that can come see you, but in many private or smaller hospitals, there's no doctor in the hospital. My father had surgery at a Tenet hospital in Atlanta, and there were no doctors in that hospital at night. So having hospitalists, now some of them are the ED doctors in smaller hospitals, that they go up and monitor ICUs and be there and being able to make that decision to do it. And then some teams, like cardiac surgeons, they've actually relinquished some of that floor work to hospitalists so they can do more cases and focus on the technical, orthopedic as well too. So I think in neurosurgery, so it depends on where they are, but they have to be part of the team. I think that's the key if you're going to use hospitalists, or some use PAs and NPs to be the manager on the floor, and I love that. Where I came from, the PA managed my patients. As long as there's communication and people know what's going on, I think it's actually the more the merrier. The more people looking at you when you're sick benefits you. Even a medical student can find something going on that could help you sometimes. So I think the more the merrier.
No, I completely agree. Our trauma service also does some acute care surgery, and they have many faculty members, but they also have a lot of nurse practitioners, and it's a similar theme of efficiency. They continue making sure the tests are getting done, that someone is watching if their blood count is dropping on a regular basis, and their jobs are so intense that they need someone to really be watching at 2 a.m., at 6 a.m., and that allows the rest of the services, those that, for instance, have a large pancreatic cancer resection, to focus on their long case on a Monday during the day. So the hospitalist, I think, is the continuity of care, the hospitalist and the nurse practitioners in the whole hospital.
So that's an interesting thing about surgery as well right now, is in terms of an opportunity for careers. You can choose, so you don't have to make that decision about what kind of practice pattern you might want to then say, oh, well, then I have to be an ER doc, because there are opportunities for what you would call surgical hospitalists now that are really much more shift work focused. Yet there's a lot of opportunity in longitudinal care. As a pediatric surgeon, I follow my patients for 17 years. I operate on them before birth, and I'm still taking care of them decades later. So there's a lot of longitudinal care and a lot of long-term patient relationship opportunities in surgery. So you can, so I think all of the options are available in surgery. You don't have to take surgery off the table because you think, oh, I want to have a longer term relationship with my patients, or I want to have shorter term lifestyle. You can find all of it in a surgical field.
If you want to know about being a nurse practitioner, that's our Bonnie McCracken is one of our nurse practitioners in trauma. She can tell you about that too. Yeah. So we have to stop because our time is up here, but we're all going to Wellman 205. So if you have a question and you didn't get it answered, we're going to be giving 3 more sessions at that time, and you can come and ask it, or you can hear the topics. I'm sure will vary. Okay. Thank you.
Thank you.
Bonnie.